without further ado, let's crack on with question number 2. So we've got a 54-year-old man that comes to A&E with a 24-hour history of a swollen, painful joint, of a knee specifically, with a fever now, okay? Different to the first one that we have. Examination shows erythema, warm, synovial effusion of the knee joint is limited, passive range of motion and tenderness on palpation. No other joint inflammation are there. Okay, you take a sample of fluid and you do light microscopy from the aspirated synovial fluid, and this is what you see. The question is not what is the diagnosis. The question is, what is the following metabolic disorders that directly predisposes to the most likely diagnosis? So the question is, which of the following metabolic disorders directly predispose, increase the risks of the most likely diagnosis? Have a think. Okay, have a think of what this could be. So we've got the patient with a single painful knee, he's got a fever, 24-hour history, very acute, warm synovial effusion. You tap the fluid, you look at under the microscope, and this is what you see. Which of the following disorders, A, B, C, D, or E, is predisposed to the most likely diagnosis? The question is, what's the most likely diagnosis? I'll give you a couple more seconds, have a think about it, and we'll go through the next slide. The way I see the differential diagnosis of a patient in any exam question with acute monoarticular arthritis is very important to consider the potential diagnosis. Now, the most differential diagnosis that you can have for a painful knee, or any monoarticular inflammatory condition, arthritis, will be number 1, septic arthritis. Could it be caused by a bacteria or fungal pathogen? Because Staph aureus is the most frequent culprit, because obviously septic arthritis is a medical emergency that requires prompt diagnosis and treatment. Otherwise, it doesn't cause joint destruction and systemic complications like sepsis. Or B2, another differential diagnosis is crystal arthropathy. We discussed about gout in the last question. There's also pseudogout, which is calcium pyrophosphate dihydrate crystals. That both can cause acute monoarticular arthritis, and both are associated with pain, swelling, erythema of the joint. Could it be number 3, reactive arthritis? So this is more of a sterile inflammatory response to a more distant infection, so in the GI or GU tract. So such organisms include things like chlamydia, salmonella, shigella, campylobacter. Or it could be traumatic arthritis. You've had a direct injury to the joint that's led to acute inflammation, pain and swelling. And osteoarthritis, of course, don't forget, which is one of the most common causes, which is a chronic condition. So that's not acute really, it's chronic. It's been there for months and years, getting worse and worse, and presents with acute exacerbation, maybe gets worse due to overuse, gym, trauma, that sort of stuff. But it more appears in weight-bearing joints, like the knee. Now, what is this? So we have all sorts of differentials here. The diagnosis that we can get is the microscopy, this compensated polarized microscopy. And what does it show? Well, what it shows, actually, it shows positively bifringent rhomboid-shaped crystals that you can see. The crystals, clearly crystalline structure, and they look rhomboid shape, okay? And this microscopy is so important because this tells you the difference between gout and pseudogout, because you see these crystals and you realize already that this is going to be crystal arthropathy. So there's going to be either gout or pseudogout. So the question is, what makes you think one or the other? Well, if number 1 is bifringence, okay? Pseudogout, CPPD crystals, they are weakly positive bifringent. So that means they appear blue. Whereas uric acid crystals, urate crystals, they're negatively bifringent. So that means they look yellow. What about the different sizes? Okay, so CPPD crystal, this is pseudogout, they're rhomboid, okay? So the rod-shaped, very blunt ends, and they're very relatively uniform shape, whereas uric acid crystals, they're very needle-like, slender rods. And I remember this because the way I remember it is the fact that gout is like walking on needles. So that's what triggers me to remember that the gout microscopy images are shaped like needles. Now, what about the actual condition then? So we know that based on the rhomboid shape in the microscopy, based on the differential diagnosis in the clinical vignette, is likely to be pseudogout, which is calcium pyrophosphate dihydrate crystal deposition, okay? Because of the monoarticular pain, that's acute, that's swelling. What about in terms of the options here? Okay, so option A is hyperphosphatasia. Now, hyperphosphatasia means that there's an increase in alkaline phosphatase levels. That does not directly predispose to pseudogout because it is low hypophosphatasia. It's a very rare inherited disorder that's characterized by low ALP levels that leads to pseudogout, because ALP, alkaline phosphatase, is responsible for hydrolyzing inorganic pyrophosphate. So its deficiency, ALP's deficiency, the enzyme's deficiency, results in excessive accumulation of calcium pyrophosphate crystals in the joint. What about B, hyperthyroidism? Well, hyperthyroidism can lead to various metabolic musculoskeletal manifestations. We know that could be things like osteoporosis, hypercalcemia, but it does not directly predispose to pseudogout itself. The presence of the rhomboid-shaped crystals in the synovial fluid is specific for CPPD crystal deposition, not hyperthyroid. What about hyperuricemia? So hyperuricemia is a key feature of gout. So that's another crystal arthropathy. And in gout, monosodium urate crystals, they deposit in the joints, causing acute severe joint pain and swelling. But we see here the crystals in the microscopy, they're negatively birefringent, and also they are rhomboid shaped. So that's why it's different. What about hypomagnesia? Well, spot on. If you chose the hypomagnesia, well done. That's the right answer. Hypomagnesia, low magnesium level, has been recognized as a predisposing factor for pseudogout. Okay, because magnesium is a cofactor for ALP, the enzyme that hydrolyzes inorganic pyrophosphate. Now, in magnesium deficiency, ALP activity is reduced. So that leads to an excessive accumulation of inorganic pyrophosphate and thus the formation of CPPD crystals. So what about hypoparathyroidism? Well, actually, you would not be too far off the mark. It is actually hyperparathyroidism, not hypoparathyroidism, that's associated with the increased risk of pseudogout, because hyperparathyroidism leads to elevated serum calcium levels, which can obviously contribute to the CPPD crystal formation. Now, conversely, hypoparathyroidism that results in hypocalcemia and hyperphosphatemia, which is not directly linked to pseudogout. So the key point to take home from this message is the fact that pseudogout is caused by CPPD crystals in the joint. It very much mimics gout, apart from the fact that there are other metabolic causes of this, and the fact that in the microscopy it looks different. Okay, think rhomboid shape, think negative birefringent.